Hi there everyone, I'm Nihal, a junior doctor from the West Midlands and a member of the RadCast Academy. Today I've prepared a teaching session on CT head interpretation for extra-axial hemorrhages. So this is quite a common topic that comes up in medical school finals exams. And so I thought it'd be really important to have a grasp on the basics to secure those easy marks. Likewise, as a junior doctor, this is quite a common presentation, and so a basic understanding of management is also very useful. So just moving on to the learning objectives for this session, okay. By the end of the session, hopefully everyone will understand the basic physics of CT in the Hounsfield Scale. Everyone will be able to outline the NICE guidelines for CT head requesting in the UK. We'll have revised the basic anatomy of the Meninges and the Calvarium, and hopefully we'll be able to understand the difference between intra-axial and extra-axial hemorrhages. Hopefully we'll be able to explain the features of extra-axial hemorrhage on CT and have a basic understanding of management. So CT was invented by this man, Sir Godfrey Hounsfield. He actually won a Nobel Prize in 1979 for his work, which really just goes to show how pivotal his work has been for the field of medicine. So just to break it down, computed means a set of mathematical equations carried out by a computer. Tomo is a series of cuts, slices or sections, and graphy means to write. So if you put that all together, it means a computer has generated an image based on a series of image slices. So CT uses X-rays to obtain images. The physics behind it is not too complicated, but it takes a while to get your head around it. So a heated cathode releases high energy electrons, which in turn release their energy as X-ray radiation. X-rays pass through tissues and hit a detector on the other side. So this information can actually be used to reconstruct the image of the body by a computer to form a 3D volume, which can then be resliced digitally to obtain sort of thinner slices, and you can reconstruct those in different planes, which we'll come on to shortly. So yeah, essentially multiple slices of images stitched together by a computer to form a 3D image. So orientation of CT scans, it takes a while to get your head around this. I use the mnemonic RALP to help me with my orientation around CT images. So R stands for right, A for anterior, L for left, and P for posterior. In CT, essentially everything is reversed, so our left is on the patient's right and vice versa. To help visualize this, imagine you're looking directly at the patient from the end of the bed. The top of the image is the anterior aspect, with the bottom being the posterior aspect. Using our mnemonic RALP, we can start on the left side, labeling the image R, and rotate clockwise 90 degrees at a time, adding on A, L, and P each time we rotate. This is the sort of system I have in place currently, and I found it useful to help me sort of visualize CT. In the case of head CT scans, for example, imagine that scrolling through the image is you going further up the head towards the tip of the skull, and you scrolling down the image is coming closer to yourself towards the base of the skull. This is all from the perspective of standing, looking at the patient from the end of the bed. And don't worry if it takes you a while to get your head around this, that's perfectly normal. You'll just find that things click into place at some point and you will understand. So, CT planes, there are 3 planes by which we can look at CT head, or any CT for that matter. I'm sure you'll remember this from first year of medical school, but the most commonly used plane is the axial plane, where we take a transverse slice through the body. We can also look at images from 2 other planes, so our sagittal plane, where you take a vertical slice through the midline of the body, and also the coronal plane, whereby we take a horizontal slice through the patient. It's easier to visualize than sort of to discuss it, so I'll leave you the images on the slide and you can just look at those to get your head around it. Now, the Hounsfield scale, this is very important when looking at CT scans. The The Hounsfield Scale is named after Sir Godfrey Hounsfield, the guy I mentioned earlier. The scale is essentially a measure of Hounsfield units, which is a measure of the density of a CT image. It ranges from -1000, which represents air, to above 1000, although bone is measured at a density of 1000 Hounsfield units. A good important thing to remember is that air is less dense than fat, which is less dense than fluid, which is less dense than bone, which is then less dense than metal. It's not really too difficult to remember, but sometimes people get mixed up with certain ones. So remember, in terms of fat versus water, fat floats on water, and therefore it's less dense. Similarly, when you're comparing soft tissue and water, soft tissue is mainly sort of intracellular fluid, but it also has some connective tissue in it. Therefore, it's going to be more dense than fluid. Okay, so yeah, the key things: fat floats on water, so it's less dense, and soft tissue, it consists of fluid and connective tissue, so it's going to be more dense than just fluid alone. And here again, we've got the Hounsfield scale. So just remember that more dense tissues absorb more X-rays. So with bone, it's dense, many X-rays are absorbed, therefore few X-rays pass through the tissues to reach the other side, and so the image appears white. With air, not many X-rays are absorbed, therefore more X-rays reach the detector, and the image appears black. So, windowing. This is quite important when considering CT. A CT window can be used to look at certain areas or tissues of interest. A small range of tissue density is selected, and that sort of provides a full grayscale spectrum from white to black, allowing for subtle changes to be seen. So, you need to define a level and a width. For example, a window with a level of 0, but a width of 400 Hounsfield units will have a range of -200 Hounsfield units to +200 Hounsfield units. So any tissue with a density of -200 Hounsfield units, when you've applied the window, that will appear like a normal CT, with -1000 Hounsfield units, like air. So -200 will appear completely black when you've applied the window. Likewise, +200 will appear completely white when you've applied the window. Whereas with a normal CT, that would normally be +1000, would appear normally white. So that allows you to sort of detect more subtle changes. And we've seen here on the image, we've got a subdural window. And by applying the window, we can see that subdural hemorrhage there a bit more clearly than before. So yeah, it can sometimes be useful in detecting extra-axial hemorrhage. So in terms of the indications for CT head, when you've got a patient who presents to A&E, you need to assess them for the following risk factors. So is the GCS less than 13 on the initial assessment? Is the GCS less than 15 at 2 hours after the injury? Is there a suspected open or depressed skull fracture? Are there signs of a basal skull fracture? Has the patient suffered a post-traumatic seizure? Is there a focal neurological deficit? And has there been more than one episode of vomiting since the head injury? If any of these risk factors are present, we need to perform a CT head scan within 1 hour of the risk factors being assessed, okay? If none of those risk factors are present, we need to consider, is the patient on any anticoagulation? If they're on anticoagulation, we're going to do the CT head, okay? It won't be within 1 hour. I believe it will be within 8 hours, okay? But we still need to do a CT head regardless. If the patient is not on anticoagulation and they've not had any of those following risk factors, which I've just mentioned, you need to consider, has there been any loss of consciousness or amnesia since the injury? If there has, we look at a new set of risk factors. So are they aged above 65? Is there a history of bleeding or clotting disorder? Was there a dangerous mechanism of injury? such as a car crash or a fall from above, I believe it's 2 meters, but don't quote me on that. And has there been more than 30 minutes of retrograde amnesia before the injury? If any of those are true, we will do a CT head. It won't be within 1 hour of the risk factors being assessed. It will be within 8 hours, but we'll do the CT head regardless. Okay, and that's quite important to be aware of because with some of these extra-axial hemorrhages, the presenting complaint will often be trauma or an injury. Okay. So now we'll just cover the anatomy of the calvarium. Okay, taking you back to first year of medical school, but the calvarium is the roof of the cranium. It consists of the skull bones separated by the suture lines. So the coronal suture separates the frontal bone from the parietal bones. The sagittal suture separates the two parietal bones. The lambdoid suture separates the occipital bone from the two parietal bones. And it's important to note that the dura mater of the meninges is situated just beneath the bones, where the bones adhere to the suture lines. So it's important later, but essentially with extradural hemorrhages, so above the dura and below this level of the skull, the hemorrhage will adhere to the suture lines and it will not cross the suture lines. Okay, and I'll cover that in a bit more detail later on. Now the anatomy of the meninges. So I use the mnemonic PAD to remember the order in which the meninges will be. So P stands for pia, A stands for arachnoid, and D stands for dura. That's from bottom to top. So P, the pia mater, adheres to the brain, and the D, dura mater, is furthest away from the brain tissue out of the meningeal layers. And now we'll work the other way. So we'll go through the layers one by one. There's the scalp, there's the skull, and then there's the dura mater. There's 2 layers. There's the periostal dura mater, which adheres to the skull, and the meningeal dura mater. Below the meningeal dura mater is the arachnoid mater, and below the arachnoid mater is the pia mater, which runs along the surface of the brain and adheres to the brain parenchyma quite closely. So it follows the brain into the sulci and the fissures and so forth. Okay, so now we're just going to sort of classify intra versus extra-axial hemorrhage. Okay, intra-axial hemorrhage refers to a bleed within the brain parenchyma or ventricles, often giving a more focal pattern of injury, whereas an extra-axial hemorrhage is a bleed between the brain and the skull. There's 3 types of extra-axial hemorrhage. There's an extradural hemorrhage, a subdural hemorrhage, and a subarachnoid hemorrhage. So extradural hemorrhages, they're also known as epidural hemorrhages, okay, and they're situated between the skull and the dura mater. They're often associated with trauma, so when you've got a extradural hemorrhage, there's often a parieto-temporal fracture, for example, and this is due to a weak part of the skull known as the pterion. The pterion is a point in the skull whereby the frontal, parietal, sphenoid, and temporal bones all meet, and it's a weak point. It overlies the middle meningeal artery, and so when you've suffered trauma to this area, it can lead to a fracture of the parieto-temporal region, which can cause a tear in the middle meningeal artery and lead to an arterial bleed. And this is what happens in an extradural hemorrhage. You get some trauma, your middle meningeal artery tears, and you suffer an arterial bleed. Now on to the CT findings, okay? So, just get my pen out. We've got a lentiform biconvex shaped hemorrhage, okay? It does not cross the suture lines, okay? So there'll be a suture line up here and a suture line down here. So this will be the lambdoid suture. It won't cross. It will just adhere to the suture lines, okay, which is unlike a subdural hemorrhage, which we'll get to. In an acute episode, blood will appear white, so hyperdense. It's often associated with a fracture, so 70% of cases are due to a parieto-temporal fracture. In terms of the management of extradural hemorrhages, urgent neurosurgical intervention is advised. Okay, if you see an extradural hemorrhage on CT scan, make sure you report it to a senior immediately. You'll need to start a referral to your local neurosurgical unit, and they'll see if the patient requires intervention. Okay, surgical treatment often involves evacuation of the clot through a series of burr holes in the skull, which allow the blood to escape and consequently reduce intracranial pressure. It can also be the case, and this has happened quite a lot in my experience, where extradural hemorrhages are managed conservatively. That is up to the discretion of the neurosurgeons. That's not your decision to make. So I'd always escalate to a senior and get in touch with the neurosurgeons to see what they want to do. Okay, on to subdural hemorrhages. Okay, these are situated between the dura and the arachnoid mater. Okay, it's due to the rupture of bridging veins caused by a high velocity movement of the head. It sort of creates a shearing force, and it ruptures the bridging veins which run from the cerebral venous segments, from the cerebral cortex into the dural sinuses. It's more likely to occur in elderly patients or alcoholics, as these patients can often have significant brain atrophy, making their bridging veins more likely to rupture. In terms of the CT findings, okay, there is a crescent-shaped lesion. Just outline it here. Okay. It does cross the suture lines, and in an acute episode, blood appears white, so hyperdense. 85% are unilateral in adults, however, around 75 to 85% are bilateral in infants, so with adults it'll be on one side, but with kids it's often the case where you get them on both sides, unfortunately. In terms of the management, similarly to extradural hemorrhages, if you see a subdural hemorrhage on CT scan, ensure you report it to a senior immediately. Make a referral to your local neurosurgical centre. You know, if they're going to proceed with surgical management, this will likely take place in the form of a craniotomy. So the neurosurgeon will sort of create a temporary flap in the skull. They'll remove the hematoma gently using suction and irrigation, so they'll allow it to sort of be washed away with the fluid. And again, this is up to the discretion of the neurosurgeons, but smaller bleeds may only require conservative management. Okay, so moving on to subarachnoid hemorrhages. This is a hemorrhage that occurs between the arachnoid and the pia meningeal layers. Okay, patients often complain of a classic thunderclap headache that comes on suddenly, as if they've been hit in the back of the head with a baseball bat. Okay, it can often occur after trauma. It can also occur in patients with berry-aneurysms, particularly in the circle of Willis, or in patients with arteriovenous malformations. Although out of all of these, berry-aneurysms are the most common cause. It's also worth noting that blood in the subarachnoid space can cause meningeal irritation, resulting in symptoms similar to meningitis. Okay. In terms of the CT findings, you often see high density blood in the sulci, basal, cisterns, and fissures. This is because the blood is overlying the pia mater. So wherever the pia mater runs, whether it runs through the sulci of the brain or the fissures, the blood will run over it, so the subarachnoid hemorrhage will follow. Subarachnoid blood can also be located in other places, such as the occipital horns of the lateral ventricles. There are certain patterns you might see depending on the location of the subarachnoid hemorrhage. For example, a hemorrhage in the suprasellar cistern will result in a large pentagon or star-shaped lesion. However, this is most likely, it's not something you need to know at medical school level or foundation year level. This is something that would be expected of radiology trainees or consultants. So in terms of the management of subarachnoid hemorrhage, Like all the other extra-axial hemorrhages, you'll need to consult with neurosurgery. In the case of a ruptured berry-aneurysm, an endovascular approach is normally taken. So this is a minimally invasive procedure whereby a catheter is inserted into the arterial system in order to reach the aneurysm in the brain. So once the catheter's reached the aneurysm has been reached, coils are inserted to prevent further bleeding of the aneurysm. This is something that's normally carried out by the neurointerventional radiologists as opposed to the neurosurgeons. But an alternative to coiling is clipping, whereby the patient undergoes cranial surgery and a clip is put on the aneurysm to seal it. Other important things in terms of management is the prevention of vasospasm. So we give calcium channel blockers like nimodipine, and that prevents vasospasm. Vasospasm is sort of a common complication that can result in brain ischemia following a subarachnoid hemorrhage. So it's something to be aware of. Okay. And again, like with the other extra-axial hemorrhages, smaller bleeds can be managed conservatively if the neurosurgeons decide. Okay, so some important additional points in terms of CT findings. All intracranial hemorrhages can cause an increase in intracranial pressure, which has the potential to exert mass effect onto the brain. So mass effect is essentially a phenomenon whereby a mass or a lesion pushes surrounding areas of brain tissue or structures, sort of compressing them. This can result in several things like midline shift, effacement of the ventricles, and herniation of brain structures. So in addition to the points we've said before, in terms of the extradural, subdural, subarachnoid hemorrhages, this is also a possibility with a large bleed. Okay, all right, guys. I know I've been sort of. I hope you've been listening because I've got a short pop quiz to just test how awake you were for the past 20 minutes. But I'll show you the questions now. Have a go. Pause the video, and then come back for the answer. Okay. Okay. So, what is the correct order of tissue densities? Have a pause of the video, and we'll come back to the answer shortly. So here's the answer, guys. The answer was A. Okay. Air is less dense than fat, which is less dense than fluid, which is less dense than soft tissue, and therefore less dense than bone. Remember, guys, fat floats on water and is therefore less dense. Okay, that's the key thing to remember. Don't get them mixed up. Okay, which of these is not, okay, don't get this mixed up, which of these is not an indication for a trauma CT head scan? Is it A, GCS of less than 15 2 hours after injury? B, a suspected open or depressed skull fracture? C, a post-traumatic seizure? D, focal neurological deficit? Or E, an episode of vomiting following trauma? Pause the video and come back in a second. Okay, guys, the answer was E, an episode of vomiting following trauma. It's a bit of a trick question, but remember, the indication for CT is more than one episode of vomiting following the head injury, okay? So, yeah, a bit harsh, but hopefully you'll remember it now. Next question, which bones intersect at the pterion? Okay, guys, so here we go. It's answer C, so it's the frontal, parietal, temporal, and sphenoid. The pterion is the weak point in the skull that's more prone to fracture. Remember, this can result in extradural hemorrhages, okay? Which artery is most commonly involved in extradural hemorrhage? Is it A, the anterior communicating artery? B, the posterior communicating artery? C, the pontine artery? D, the basilar artery? And E, the middle meningeal artery? Pause the video. Okay guys, the answer was E, the middle meningeal artery. The last question sort of gave it away, but the middle meningeal artery runs directly underneath the pterion, so trauma to the pterion can result in a fracture, which can also result in tearing of the middle meningeal artery, leading to an arterial bleed and an extradural hemorrhage. Okay. What best describes the CT image shown? Is it A, subacute extradural hemorrhage? Is it B, a chronic subdural hemorrhage? C, an acute subarachnoid hemorrhage? D, an acute on chronic subdural hemorrhage? Or E, an intraparenchymal hemorrhage? Just pause the video. The answer is D, an acute on chronic subdural hemorrhage. Okay, so remember, with acute bleeds, which are between sort of hours to days, new blood is white. Subacute, so days to weeks, blood is typically a bit more grey. And chronic blood appears dark, so that's weeks to months. Okay, so here, just outline it here. Here we sort of got our acute bleed, okay, and here is more of our chronic bleed, okay, and that's just the basics of it. So it's an acute on chronic subdural hemorrhage. Okay guys, so I hope you enjoyed the talk. In terms of the learning outcomes for this session, hopefully today you sort of understand the basics of CT and the Hounsfield scale. Okay, there's quite a lot of principles in terms of the physics to sort of get your head around, but hopefully we've covered them sort of at a beginner level, and you can read on further to gain a better understanding. Hopefully you're all aware now of the NICE guidance for trauma CT head requests in the UK. We've revised the anatomy of the Meninges and the Calvarium. Hopefully now you can differentiate between intra-axial and extra-axial hemorrhage, and most importantly explain the features of extra-axial hemorrhage on CT, and just have a basic understanding of management. So if you come across a patient with an extradural hemorrhage in the emergency department, you know to escalate to a senior, you know to contact neurosurgery urgently. Okay, and those are the most important things, really. Yeah, in terms of my references, okay, here's my reference slide. So I'll just point out a few excellent resources really that have helped me develop my radiology knowledge, because I didn't really receive any during medical school, to be honest. First is Radiopedia, which is a platform full of like sort of interesting cases of different pathologies. They also have learning resources for common radiological presentations, which I used for this to help make this presentation. Another good resource is Radiology Cafe, which offers revision tips and general information about sort of radiology training, what the life of a consultant is like, amongst other things. And finally, there's a really good book written by a consultant radiologist and a radiology registrar covering all the basic radiological pathologies and the physics behind the imaging modalities. It's called Radiology Basics Cross-Sectional Imaging. This is something I've found really useful in sort of picking up the basics, and it has helped my understanding of the physics, for sure. Well guys, that's the end of my presentation. I hope it's been of some educational benefit, if at all. I would also appreciate if you left some feedback so I knew what was done well, and also if you could let me know what areas I could improve upon for future teaching sessions. Cheers guys.